If it happens to be that I am the attending of that day, when I receive the patient, then you're fried. You go back to internship, and then we put you at the very beginning, especially if you are using cell phones when we are talking. Okay? So keep the cases clean. It helps everybody. Okay, so after that, once you have dichotomized type 1 and type 2 diabetes, there are next questions to ask, okay? The first question you ask in a type 1 diabetic patient is the patient using a pump? If you answer yes, what's the next step? What do you think is the next step? Anybody here is using a pump? Anybody with diabetes? None. What do you do with a patient who's type 1 and is using a pump? Doctor. Keep them on the pump. Doctor. No, you know, you are, well, yes. It doesn't matter. It's for you that you are going to learn what to do. What do you do with a patient with a pump? You are there at the bedside? Huh? Mm-hmm. How do you make those assessments? Discussion. Tell me. I am the patient. Discuss with me.
I would ask you, tell me how you operate your pump. What you know about it, how you change it.
Uh-huh. Oh, you want to change? You are asking me? You want me to teach you how to change it? You want me to teach you, or you want show me? Come. Come. I'm going to show you. Yeah, I didn't bring a pump, but we're going to imagine this is a pump, okay? Okay. So what do you want me to show you? Okay. So this is how I do my changes in basal rate.
I'll get the instructions and make sure you're doing it right.
Oh, you get the instructions. Go and get them. Do you know what to do with a patient that has a pump? He says, I'm going to make sure that he knows. And he's asking the patient, do you know how to do this? What does the patient going to tell you? I know, and please bring a doctor that knows because you don't know. You're asking me. What do we do? You intern, 5 o'clock in the morning, last patient before you go home. You have to understand if the patient really knows how to handle the pump, okay? But more than that, and more important, is the outcome. Is the patient a good user of the pump? How do we judge the outcome of the pump?
Check the blood sugar.
Check blood sugar. Check what? Which one? The A1C. If the patient tells you, oh my God, I've been using the pump for 15 years, and you go to the chart and run a check on A1Cs in the last 3 or 4 years, 16, 17, 15, 14, that patient doesn't know how to handle the pump, period, right? Patient has a hemoglobin A1C of 5, 6%. That's it, right? What do you do with that pump? Nothing. Let him be or let her be, okay? Now, we can come, the endocrinologist or the glycemia management team, we can come and evaluate all the parameters and so on and whatever, but if the patient has good hemoglobin A1C, if the patient has been using the pump for as many years as you want, that patient should be left alone. Don't touch it. If the patient has a 15, 16%, you might as well say, I'm sorry, right now we cannot take the chances of this patient handling the glycemia. We have to do it ourselves. Got it? So in the patient that does not fulfill criteria for full management of the pump, then has to go into treatment by us. That clear? The patient is not using a pump, is type 1 diabetes, goes directly to insulin, right? The patient is type 2, okay? The next question might be a little bit intriguing to you guys. The question in your mind is the patient candidate for a DPP-4? What the heck is a DPP-4? Doctors. You. Yes, you. She's chief. I cannot mess up with them. They will go to Dr. Blinker and accuse me of harassment. It triggers the release of insulin. Yeah. What is a DPP-4? Not you. Yes, you. Uh-huh. And what the heck that has to do with insulin or diabetes? Doctors from China. My doctor Japanese from Kyoto. My 3 cases, the case Western Reserve guy. What is DPP-4? He says that it inhibits the breakdown of GLP-1, whatever that is. So, speak. No, I know, but what is the DPP-4? In practical terms. Yeah, but what does it? Yeah, no, you're right, but he says it inhibits the breakdown of GLP-1, and he says it triggers insulin release. No. Doctors, you're looking very intensively at me.
I'm that kind of guy. I was going to say, doesn't allow, when you don't break down the GLP-1, that increases the amount of insulin that's released.
And then?
And then your blood sugar comes down.
So there is a system, okay, in the body of everybody, which announces to the pancreas that food is coming. And when food comes and sugar increases, it intensifies the message to the pancreas. So it begins before, during, and after absorption of glucose. And it has a receptor in the beta cell, and the beta cell releases insulin. With one peculiarity. If the sugar level doesn't go above 100, the signal is 0, meaning it does not work. So medications based on this system don't cause hypoglycemia. So DPP-4, as he said, makes the GLP-1, which is this signal that goes into the blood to tell the pancreas to begin to produce insulin, has a half-life, that GLP-1 of around 1 minute or 2. So in order to increase the half-life of the GLP-1, we use inhibitors of the destructor of the GLP-1, in this case, the DPP-4 enzyme, okay? So two lectures ago, this was not included in the management of the patient with type 2 diabetes in the hospital. And then in sequence, at least 6 trials were advanced to show that actually the use of DPP-4s is useful in the patient with type 2 diabetes, especially the patient that has a good level of C-peptide, okay? And it has been incorporated now into the treatment of type 2 diabetes in the hospital. So I'm going to show you I want to get to, okay, right here. No, not that one. Well, this is the paper, the seminal paper, the first one to test it in a randomized manner. And I want you just to see a graphic. Why did you stop? What's happening to this? So you can see here a comparison of the two groups, okay? A group in which the patients receive the classical approach that you will see in a moment, which is the sole use of insulin for the treatment of diabetes in type 2 diabetic patients in the hospital, versus a group in which the patients receive one shot of basal insulin with the addition, in this case, of sitagliptin, which is Januvia, and you can see the glycemia, the average one. There was absolutely no difference, okay? But there was one big difference, and that is because of this property of the GLP-1 not giving you hypoglycemia tendency, there was much less hypoglycemia on the group of patients that received the DPP-4 versus the patients that receive Humalog as the base for meal insulinization. So we have been using this here in the hospital, and so far we have had a good response in our patients, okay? The only problem, okay, is this. This is the inclusion criteria that they use for the clinical trial, which is very, very restrictive, okay? Some of these patients definitely cannot be on sitagliptin no matter what, and that is patients who have a history of pancreatitis or history of medullary cancer of the thyroid gland, okay, because that has been associated with the use of this medication, okay? Also, this is restrictive as an inclusion criteria in a clinical trial. They use it like that. We have seen patients here with glucoses at entry of 500, 600, that later on they consult on us 2 or 3 days, and we use the sitagliptin and it works nicely, okay? So I wouldn't use too much these criteria, okay? They don't include the patients with type 1 or DKAs and so on, okay? So there's a good bunch of patients out there in Metro, in the hospital, that could be good candidates for the use of sitagliptin as a treatment and in addition to basal insulin in the hospital. So this is the first question. Once you have defined that the patient has type 2 diabetes, okay, especially if you have a good C-peptide, okay, if the patient is not a candidate, then the patient needs to go into basal bolus in a complete manner, okay? Does that give you a panorama how to traverse that in 10 minutes when you're seeing the patient, okay? First of all, type 2, type 1. Type 1, pump, good, leave it alone. Not good, let's go to insulin. Type 2 diabetic patient. Patient has good C-peptide. Patient has a good history, more or less, of A1C, or not so bad. Glycemia, as mentioned, less than 600. Good candidate for sitagliptin, then start sitagliptin basal bolus, okay? Basal. Yeah. No, it's present, actually. So the C-peptide of the type 1 diabetic patient is basically 0. You don't find it. The patient with type 2 diabetes oscillates between the normal levels all the way to 5 or 6 times the upper limit of normal. So it's just the presence of C-peptide, okay? Questions about this? Okay, clear, transparent? Have you ever used, any one of you, a DPP-4 in the hospital? So that's the only agent, PO, that I am recommending for you guys. So what are you going to do with the rest? The patient was taking metformin. The patient was taking empagliflozin. The patient was taking Amaryl. Which one of those can we use in the hospital, doctor? I don't hear.
I would hold them.
You would hold it. Would you? Who would like to continue with metformin? It's the number one agent that you have to use in type 2 diabetic patients, right? Well, you see now the big difference, right? If you use metformin in the hospital and the patient develops lactic acidosis and dies, you will not be a gastroenterologist ever again in your life. Actually, you will not be a doctor. They will withdraw your license. They will put you in jail. You will stay over there 10 years. You will get the second wave of COVID, develop a pneumonia, and then it will be severe. You come back to Metro, they intubate you, and that's it. You're done. And that's because you put a patient on metformin in the hospital. Okay? Right? Sulfonylureas also, they are not used. They cause hypoglycemia too much. So pretty much you have two things that you need to learn for the hospital management. One of them, DPP-4s, okay? What is the management of DPP-4s? What do you know about dosing on these guys? Nothing. You want to learn one thing and only one thing? Choose one of those guys that doesn't need renal adjustment. That's the way I am. If there's a medication that needs to be dose adjusted for liver, for kidney, for this and for that, I throw it away. I want to be simple. And of all the DPP-4s, we have only one that has only one dose and doesn't need to be dose renal adjusted. And that is not sitagliptin. It is linagliptin. And actually, when you go to the formulary and you look for a DPP-4 in the hospital formulary, you're not going to find anything but linagliptin. Okay? Just to make it easy on you guys. Okay? So linagliptin is the one because of that renal adjustment. Okay? So let's move a little bit into how in Garhaven we calculate the amount of insulin that the patient is going to need while in the hospital for treatment of their diabetes. So let's go first to the type 1, I guess. How do we do it? How do we calculate the initial dose? Who wants to say, I know? Who's talking? Once again, the DPP-4 guy. No, pump guy. You're the pump guy. Tell me. 0.5 what? Come over here. Oh, man. Tell them. Preach the insulin Bible.
I thought I remembered 0.3 to 0.5 milligrams per kilogram to start out.
So, sit down. What the heck, why not? One huge error. Just repeat it. Take out this and talk to them.
0.3 to 0.5 milligrams per kilogram.
What's wrong on that? Like that? Huh? You didn't capture the error. What's the error? A simple error. A simple error. But if you do it in an order in a hospital, that's it. The pharmacist is going to come at you. What the hell are you talking about? Blah, blah, blah. Tell me, what's the error? It's in unit. Unfortunately, it's in unit.
Oh, yeah.
Unfortunately, you said milligrams 3 times. So once again, you are going to end up like, who was this guy in jail? Whoever went to jail, okay? Okay, so there are 2 ways of doing it. The simple and the not so simple way, okay? I'm going to give you first the simple, but then you will see later that we're going to percolate into the hospital with a slightly more sophisticated approach. Type 2 diabetic patients, type 1 diabetic patients, right? For the type 2 diabetic patient and for the type 1, I calculate initially the total daily dose. How much is the total amount of insulin? How do I do it? Well, I take the type of diabetes, okay, and use half of that, okay, meaning 50% of the type of diabetes. So if the patient is a type 2, it boils down to 1, right? Type 1 is 0.5. Then unit per kilogram per day. That's the total daily estimated dose. So if you're type 1 and you need to calculate the total daily dose and you don't have any memory to remember what you're going to see in the next slide, then you say it is type 1 half, it is 100 kilos. How much is the total daily dose, doctors? No, doing that. Doctors. Thank you. How much is it? Huh? 100 kilos, type 1, total daily estimated dose. Huh? How much is it? I don't hear it. Stronger. 50 units per day. Per day. 100 kilos, guys. Type 1. For the type 2, how much it would be? 100. 1 times 100 is very easy math, right? Now, you take that and cut it in half. So 50, it will be 25, 25. 25 for the basal, 25 for the meal, insulin. And then 25, you divide it into breakfast, lunch, and dinners. Got me? Is it difficult? Then say no. Everybody, is it difficult? You. Okay, so a type 2, who weighs 78 kilos, like this, basal and meals. And then 2020 sounds like the years. How much would it be? So you have to allocate 6 or 7 for the meals. It sounds quick, right? And you see that there are variations to that. So when the work that I'm doing right now with the quality control group finishes, the way to do it is going to be slightly different, okay? Type 1 diabetic patient, okay? For your basal, we use glargine, Lantus, okay? Why? Because it's long-acting, it's stable, and it's the cheapest one. Okay, Tresiba would be my choice, but it is very expensive, okay? So we're going to be segregating the patients into different levels of A1C, okay, at entry, okay? Because it's not the same to treat someone who has a perfect A1C in whom, even when my estimated dose is different, the patient has shown me with an A1C that he knows what he's doing, or she, right? So in that particular patient, I just leave it as is. In the patient that is not so well controlled, but not so terrible, then we go a little bit higher, okay? And then we use this initiation of basal insulin on the patients that are really poorly controlled, okay? This is going to be plastered in EPIC when we finish all the smart sets, okay? And for meals, okay, again, we keep the same home dose on those guys that are good, and then we divide the dosage of the Lantus, okay, for the breakfast, the lunch, and the supper, but we divide it a little bit different. It's not only 1/3, 1/3, 1/3, but 30, 40, and 40%, okay? Are you with me? So it's pretty much the same. It's just that I want to begin to consider the prior metabolic control of the patient into the selection of the dose for basal and for meal insulin, okay? But if you want to stick only to the half of the dose, okay, half of the type of diabetes, to calculate the total daily dose, be my guest. That would be perfectly okay. Now, after you calculate the total daily dose, okay, let's assume that you have a 200-kilogram guy in front of you, okay, type 2. How much would be the basal insulin regimen? The basal and bolus. Doctors, on the back, not you. It's 200 kilo. How much would be the total daily dose? 200. And how much for basal? How much for foods? 100 divided by 3? So 33, 33, 33. Would you dare to write down that on the paper? Would you? Or would you be scared of the darkness?
I'd probably.
Yes, you are.
I'd be terrified.
You'd be terrified? Honest to God. Who would write that order? Who would write the order that he just basically said? 100 units of Lantus right now, 4 o'clock in the morning. In turn, I have to present my case to the senior resident and then to the attendee. Would you do it? Would you do it? Who would do it? A1C is 9%. I'm going to put it even harder for you. 8%. Who would write down 100 units of Lantus right now? Huh? So you are wimps. All of you. Right? Yes, you are. Yes, you are. You have seen this big mass of tissues walking to you, and you freak out. Oh my gosh, 100 units. So when you are scared, okay, when you're scared about the dose, if it's too high, the total daily dose, introduce your win factor. What is the win factor? It's the percent that you want to reduce of that dose. Between 50 and 100, don't go at 10% of the dose, okay? You with me? My recommendation is to be kind of like the 60, 70% wins, okay? So it would not be 100, it would be 60, and then 20, 20, 20. Now, what you are doing at that moment is that you might not be getting the right dose. Maybe the patient will be hyperglycemic a little bit in the next 2 days, but you are protecting the patient from ketoacidosis, period. And that's a big one, okay? So, but if you wimp out completely, then you run the risk of letting the patient go into ketoacidosis, okay? So, in summary, right now, from what we have said, you can use half of the type of diabetes. If you are wimpy as you are, then cut to 70%, between 70, 60, or 50%, more towards the 60, 70%, okay? Does that give you some room? Does that give you some tools to begin the insulin on the patient? Yes or no? Who has questions about this? Questions? You don't have any questions? Can I do the quiz now? And if you get it wrong, you go back to being an AI? Seriously. Okay, so anyhow, slide scale insulin. Okay? What the heck is a slide scale? Speak loud.
So let's say a patient has hyperglycemia for his weight, and there should be a certain amount of acid
So the slide scale is the stupidity factor. Stupidity factor. It is the amount of insulin that you didn't dare to calculate or take into the patient, but you reserve it just in case the sugar is too high, right? That's what a slide scale is. So it's just an amount of insulin that you add to the meal insulin to correct, hopefully for the finger stick before the meal, and try to bring it down, okay, along with the meal, okay? And let me show you in Epic. Do you know about the smart orders in Epic? Have you gone to the diabetes set? Who has done that? And you see over there that there are 10 slide scales, right? Who doesn't know about that set of orders? Raise your hand. So everybody knows. And only 3 of you have used it. And it doesn't come square. Who has opened the smart set for diabetes, where you have the land to the human log and the slide scales and all that kind of stuff? Raise your hand. Hi. 1, 2, 3, 4. You have not used it? Huh? You have not. Do you know how to get to it? You know how to get into a smart set. So you go to the smart set and there's a set of orders for diabetes. And all the orders for diabetes management are right there, including bibliographical references for justifications and so on. So get used to it. You want to see what it is? I can put it on the screen and then go for it. Do you want me to do that? Yes or